Since the introduction of cited research measurement, he has been every year named amongst the world's most cited researcher. In between all this work, he has a fantastic nature and has given of himself and has gone on 24 development missions to Africa and Asia. Some of you may know that the University of Dundee and the United Nations Sustainability Development Goals number 5 is gender equality. And as one of the co-leads of your sustainability committee in the School of Medicine, it is with great pleasure I invite Mark to come and talk to us about sex and gender sensitivities in cardiovascular research. Thank you, Mark.
Hello, everybody. Thank you for coming to this talk, and thank you to Jill for the introduction and for inviting me in the first place, and of course to the William Walker legacy, who paid for all this. So I'm very pleased to be back in Dundee. It's always a thrill to come here. But I have to say that when I walked out of the station yesterday, came out onto the sort of patio area outside the station, and I was met by this drizzle, that's sort of mega drops of rain that you seem to get up here. And then a drunk guy come straight up in front of me, started babbling some incoherent rubbish at me. I mean, I thought, oh, this is really what Dundee's all about. So anyway, good to be back in Dundee. And certainly, if there is a God, he had one of his really good days when he designed Scotland as a whole, which is just a fantastic country, which I love being in. So nice to be back here. I worked here a long, long time ago, more years ago than I'd like to mention. With Hugh Tunstall-Pedo, who ran the cardiovascular epidemiology unit, which was in Nine Wells Hospital. And thereafter, I've worked quite a bit over the years with Hugh and others at Dundee. But anyway, I must get onto the remit today, which is to talk about sex differences in cardiovascular disease. So I'm going to give you I'm going to give you an introduction basically to the work that I've been doing for about 15, 20 years now on sex differences. Most of the stuff is research that's involved in my team. And I'll give you the first name of the people who did the papers. No, I'm not doing this to sort of try and impress people for the fact that it's research that we've done. It's more the fact that I'm lazy. And I don't actually read the literature as much as I should. I rely on other people to do that. So bear with me a little bit if you think it's being a bit sort of selfish to concentrate on what I've been doing. So who gets heart disease? I thought I'd start with this. If you ask somebody what's a typical sort of person who gets heart disease, they'd probably think it's somebody like this, who's obviously obese, smokes, has a poor diet, and he drinks. And the most important thing, I think, is the he. I think most people would think of men as being the people who get heart disease. But of course, that's not true, as you probably all know. And this slide is people at the American Heart Association meeting. All of these women have had heart disease. And you can see it's different ages, different ethnic groups. So women get heart disease as well. And I've looked at the global burden of disease data. Now, I picked 2019 because if you look at the latest data which global burden of disease produced, it's 2021, and it's very much biased by COVID, which I know it's not exactly gone away, but it's not as important as it was then. Anyway, to some extent, that sort of messes up the data. Actually, it doesn't make that much difference for cardiovascular disease. Anyway, these are global burden of disease data for globally and for Scotland specifically. Of course, the Scottish data is also produced in Scotland. So I'll give you some of those data in a minute, but at the moment I wanted to make a fair comparison between the two. So globally, where does cardiovascular disease come into the rankings of causes of death? Globally, for both women and men, CHD is number 1, strokes number 2. In Scotland, it's almost the same, except men go down, stroke goes down to 3rd place for stroke goes down to 3rd place in the male ranking list. And even if you look in terms of the cancers, In Scotland, I mean, most people think of breast cancer being the most important thing for women in the cancer area. But you'll see if you look down the list over this side for women, lung cancer and colorectal cancer are both higher in the rankings than breast cancer. So cardiovascular disease, the two major manifestations being coronary heart disease and stroke, are the most important, I think it's fair to say, in women globally and in Scotland, and in men there's just this slight issue with lung cancer being a bit higher than stroke, but it's pretty much the same. So that's for deaths, and we can also look with the global burden of disease data about DALYs, disability adjusted life years, and CHD and stroke, again, are pretty much near the top for both men and women globally, not just in Western society. And in Scotland, again, it's the same, pretty much the same. Stroke was down to 4th now, but it's still there. And COPD is also very important as well, I should point out, both for deaths and DALYs. So the message from this is that cardiovascular disease is a problem in women as well as men. In fact, it's a big problem in women. Now, when people talk about sex, they often make this distinction that it's sex and gender. So sex is the biological issue. Gender is the behavioral issue, if I can call it an issue. The characterization, anyway. I find it's, for me, it's quite useful to think of it in 3 different ways, which is what I'm going to try and do today. So the behavioral one I've got at the top left of this triangle, that's the sort of gender, I guess, area. And the other 2 are probably what people would call sex differences, although some of these are actually also due to what people talk about gender differences. Anyway, for me, I'm going to do it in this three different ways. So at the bottom, I've got clinical, and there I'm looking at level of risk. I've already shown you that it's a big risk in women as it is in men. We'll have a look at the differences in a minute. The prevalence of risk factors, then the associations of risk factors, and then the single sex specific factors, which also we have to take account of when looking at sex differences. And I'll call it sex differences and not keep saying sex and gender, just for brevity. And then the top right, I've said professional. So some of the differences are due to things like the difference in screening between men and women and the treatments given to men and women. And I'll try and show you, well, I will show you some examples of that. Okay, so the rates now. So this paper that a master's student of mine at Oxford did a few years ago, we looked at the global burden of disease again, using their data, which is, I think is really good. These charts looking at the rates of heart disease on the left and stroke on the right at different age groups for both men, boys in blue, and girls in red, of course, as is traditional, or at least pink perhaps would be more better, but anyway, red. And it's on a log scale. Now we in the paper, it's got lots and lots of countries, but I picked out one country. I think this was the figures actually in the paper, if I remember rightly. We've got one country from each of 5 regions of the world. So it's Russia, South Africa, South Korea, United Kingdom, United States. And everyone, you can see, if you look at the heart disease, the left-hand charts, the mortality rates are higher in men than they are at women at all ages. There's a bit of catching up as you get to the top levels, the highest ages, I mean. And to some extent, you can see that it's a sort of it's 2 different slopes. The slope for women is a little bit steeper than the slope for men, so they tend to catch up a little bit in old age. For stroke, there's a much less a difference. Looking to the right-hand columns now, there's much less difference. It's still like men have slightly higher risks, but when it gets to the older age groups, when there's most women populate the older age groups, of course, a lot more than men because they live longer. There's really very little difference between them. But anyway, that's global examples. It's the same in every country that we've looked at. I thought I'd look at the Scottish statistics. So I did this a couple of weeks ago. These are from the government statistics. So CHD death again on the left and stroke death on the right. And again, it's looking at different ages. And if you look down the rates there, men have got higher rates in each cell, apart from when we get over to the stroke deaths in the highest age group of greater than 75, where women have slightly higher, but it's only slightly higher. Deaths on the top two parts of this figure, and incidence, which is a preliminary results, they say, but actually the preliminary results never seem to get updated, as far as I can see, going back to old data. Again, it's the same message that men have higher rates. And in fact, I've looked here at the male to female differences, and they're about, for heart disease, they're about 2 to 3 for both death and incidence, until you get to the really high age groups, greater than 75, where of course the confidence intervals around that would be higher anyway. For stroke, it's a bit less. It's about between 1 and 1.6. So the message is that men do worse in cardiovascular disease. And that's underlying truth everywhere you look. It doesn't matter what age groups you're talking about, men do worse. It doesn't matter when you look at subgroups of risk factor levels. For example, in one paper, we looked at smoking, hypertension, and diabetes, those 3 risk factors. If you look at people with those 3 risk factors, although, as I'm going to show you in a moment, the next slide, in fact, I think, women have higher relative risks than men. Even in the groups where women have higher relative risks, the rates in men is still higher. So it's not the next slide. I've forgotten my ordering. Anyway, in a minute, I'm going to show you the results for diabetes. So I said I'd look at, I talked about the difference between biological and behavioral a minute ago. So potential biological reasons why there could be a disadvantage for women. So we said it, disadvantage for men. Now I'm going to look at where there are the places where there's a disadvantage for women. So first of all, there's this argument that estrogen protects women from heart disease and stroke. Personally, I feel that's a bit dangerous. I've had women say to me, well, I'm okay because I'm premenopausal. But actually, if you look at the statistics, particularly with the UK Biobank, which has got a lot of data on the male and female hormones, there isn't really that much of an effect of estrogen when you've taken account of age. I mean, to me, it's probably, just, I know this is a very controversial thing to say, but it seems to me it's so highly correlated with aging that it could be just age that's the issue. Anyway, that's a potential issue. Some classical risk factors are more prevalent. This is probably most likely true for obesity. The other risk factors like hypertension, I don't think there's that much difference, to be honest. I'm using the non-communicable diseases risk factor data, which is from about 190 countries, I think, if I remember rightly, looking at how obesity levels have changed, overweight and obesity, in fact, over recent years. And women do worse in many countries, not in the Western countries, but in a lot of the world, which of course is not in Western countries. Women still have higher rates of obesity and overweight than do men. Probably not true in Scotland, I think. Some classical risk factors have a greater proportional effect. That's what I'm going to talk about in a minute. And then finally, the next 2 slides will be on the reproductive factors. So reproductive factors seem to be independent cardiovascular risk factors. And the bottom one is probably pretty obvious. If the woman's had preeclampsia or gestational diabetes, they've got more chance later on of having hypertension and diabetes, and therefore a greater future risk of cardiovascular disease. In fact, with a big set of data we looked at in New South Wales, we found that women who have pregnancy-induced hypertension within the first, I forget exactly how long, but it's the first few weeks of pregnancy. If they had that, pregnancy-induced hypertension, and they smoked, they had about 25 times the risk of getting heart disease in the next 15, 20 years, which is huge. I mean, a 25% extra risk. It's almost unheard of in epidemiology. Anyway, for reproductive factors then, we use the UK Biobank quite a lot. And if any of you have not seen the UK Biobank yet, it's a fantastic resource with over 500,000 people. Greater than 50% of which are women. This is a fairly early paper because it was 2018. There's a lot more follow-up since then. But anyway, we found in this paper that all these reproductive issues in women, early menarche, menopause, age at first birth, history of miscarriage, stillbirth or hysterectomy, and having more children, are all independently associated with future cardiovascular disease. So that's after adjusting for lots of risk factors taken at baseline in the UK Biobank. So this is the UK Biobank asked for history of these things before. Obviously, it wasn't just from birth. The UK Biobank's taking people who are middle-aged, and the questions go back in time. So that's obviously a big factor, I think, in women's extra risk of cardiovascular disease, which in some ways potentially could be interventions could happen, possibly. Now, the trouble is, all these things are in women alone. So how can I put this into a talk on sex differences? Now, the one exception with all of this list, of course, is the bottom one, having more children. Now, at the time we did this paper, lots of people had said, well, we found that women who have more children have extra risk of cardiovascular disease. And there's all sorts of hypotheses put about things, for example, that it's to do with breastfeeding, that with more children, they had less chance to do the breastfeeding, blah, 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 whatever it was. Anyway, there was lots of things like that were said about the biological explanations. But we thought, well, having more children, of course, men, you could look at men as well. So we did. And this is what you find when you look at men as well, that in both cases, there is largely an increasing risk of coronary heart disease and stroke as you have more children. So most likely this is a social explanation rather than something to do with biology. Most likely, and I don't know for sure, of course. But you could well imagine, I mean, I'm a father of twins, and we went overnight from 2 people on 2 salaries to 4 on 1 salary. So, it could be just, it's an economic issue. So anyway, one message I always try and put out to people is if you're looking at women's health, try and have a control group of men whenever you can. I'll come back to that issue a little bit later as well. So here's the example I said a minute ago that was going to come rather earlier than I've forgotten about. So this is looking at the relative risks of heart disease on the left-hand side and stroke on the right-hand side, as with other slides. And again, I put blue for men and red for women. So it's a little bit hard to understand this, I think. So if you look at the left-hand blue bar, it's saying that the relative risk, diabetes compared to not diabetes, for cardiovascular disease amongst men is at just over 2. So in other words, men have got about twice the risk of getting cardiovascular disease if they have diabetes than if they don't. If you look at the red bar next to that for women, you can see it's higher. It's higher than 2.5. It's not as high as 3, but it's somewhere between 2.5 and 3. So women have higher relative risk. Now, what that means is that women have got greater excess risk after they have diabetes than do men. It doesn't say that men don't have risk, but women have higher excess risk. In fact, it's 44% higher if you do the maths on this. And for stroke, it's a similar sort of message, but it's a 27% extra risk. So again, it's a sort of a message that heart disease, things tend to be a little bit more extreme than they do in stroke, but there's still the evidence in stroke of sex differences. And these papers were, the main authors of these papers were Rachel Huxley and Sonna Peters, who both have higher positions in, Huxley is actually a dean of faculty these days at Deakin University. Anyway, the people who've worked in my group in Sydney, or in this case in Oxford as well. We were in Oxford, we're now at Imperial College, I should say. If anybody's interested, I can tell you about the George Institute, but I won't go on about that. Now, it's all very well to say you found a difference, but what does it actually mean? I mean, why is it this difference? And it's quite hard to say in a lot of cases, but a possible explanation, I think it probably is the explanation, to be honest, rather than possible, is this business about the different way that women and men store fat. And basically, without going into a lot of detail, if you look at the cartoon, what I'm trying to show here is that women are more obese at the time they get diabetes than are men. So unfortunately, I mean, I'm going to pull in my tummy as I say this. As you get older, you tend to put on a bit more weight, I'm afraid. I'm the same weight as I was when I was young, but it's all come off the arms, it's all gone on the tummy, I'm afraid. For women, it seems as if they have this more delayed effect because they've got the cardiometabolic reserves. And we can sort of prove this from looking at the Sky Diabetes, I'm told it's now called, the Diabetes Registry, as I think it used to be called. And this I've had nothing to do with this paper, but this is looking at the average BMI at age of diagnosis. And you can see that for every single age at diagnosis of diabetes, women had higher average BMI within this beautiful data set. And also we've done a Mendelian randomization analysis where it looks from that again as if it's the difference in the time, the relative BMI at time of diabetes, which probably explains the diabetes differential in risk of cardiovascular disease. So, you know, looking at collecting the evidence is great, but you really need to say, you know, what's under the hood of seeing this difference. But I haven't got time to go into too much of that today. Okay, so that's biological reasons. Now going on to the professional reasons. So textbook symptoms, at least traditionally, were based on the male model. Obviously, this has changed over time, and I'm sure modern textbooks would never do this. But still, a lot of people have learned from old textbooks. Women have non-textbook symptoms of cardiovascular disease. The sort of typical things people say is that women have more pains in the shoulders, for example, than men who have the classic clutching their tummy, clutching their chest, whatever, when they've had a pain in their heart. So they may be missed. If people are using old textbooks, I suppose, or they're influenced by people who've read old textbooks, they may miss the symptoms. And there's a lot of evidence for this. And I'll show you one example, which may or may not convince you this is a possibility. Women may not be screened as intensely as men. I'm sure that's true. Well, we know it's true from a lot of data. Women may not be treated as well as men. I'll give an example of that in a minute. And I think there's a big issue about randomized controlled trials. Women tend to be underrepresented in trials, which of course is the gold standard for evidence. But some anti-cardiovascular drugs might work differently in women and men. Global female, the last one is about, this is just a comment, I suppose, about sex and gender research tends to get lumped into women's health, but it's not women's health, it's everybody's health. You know, it could affect them. There's lots of things that affect men more than they do women. I've told you cardiovascular disease has got a higher risk in men than it is in women, which is an obvious example, but there's things like suicide, whatever. Female research is skewed to mother and child health, the so-called bikini health, rather than the whole body. In fact, indeed, the whole age range of women. It's, you know, not every woman has a child, and there's not every woman that's in childbearing ages. And it doesn't prioritize the health research, doesn't prioritize the major risk factors affecting actually the major diseases, which I've already shown you is cardiovascular disease. So that's a bit of an issue, I think. Right, so the example of secondary healthcare, sex differences. So these data come from a European Society of Cardiology study, where the person who's the first author of this, she came to Oxford to work with us on this. So it's using data from Eurospire, if you've heard of that. So looking at using European targets for treatments and lifestyle interventions after a myocardial infarct, what's the difference between men and women in this particular analysis? And the data, as it says at the top, came from Europe, Asia, and the Middle East. So it's not just in Europe, and this is applying that European standards in different countries. Now, I've got the odds ratio here comparing women to men. For example, if you look at the very top line, it says BP on target. So For women, 45% were on target, and for men it was 38%. So that means that the odds ratio is greater than 1. In fact, women were 31% more likely to get blood pressure on target. And again, this is a sort of a message that seems to come out from a lot of data I've seen, that women tend to do better with hypertension than men, but other things women do worse, in particular the lipids. So if you look further down the figure, you see that everything else goes on the left-hand side of the line of unity. So the odds ratio is less than 1. So women do worse. So that favours men, as it says on the bottom scale. So generally, women do worse. When it comes to smoking, the only thing, again, there's only one exception, which is at the top of the figure, the bottom half of the top of the bottom half of the figure. That's in smoking. So women are more likely to be non-smokers. But this is highly influenced by the fact that Asia and Middle East are included here, because in those countries, there's very few women smoke. It's usually about between 2 and 5% in most Asian and Middle Eastern countries, even when the male rates are up to 70%. So women do worse for most things when it comes to management and secondary healthcare after a myocardial infarct. However, again, another message I always try and put across when you're looking at sex differences is don't forget the whole picture. And to me, the really striking thing about this is the numbers where it says all treatment targets. All treatment targets over here. Okay, only 6% of women had all treatment targets. And they're not unreasonable targets. But 8% of men, they did better, but I mean, is 8% good? Come on. So it's really, the main message from this has to be that people as a whole don't get treatment targets achieved, but women do worse than men. This example now is from New South Wales. So we have this is another data set, another one I talked about earlier. I've got data on every person who went into a New South Wales hospital over about a 20-year period. And in this particular example, we're looking at stroke. And we've looked at people who got admitted to Australian hospitals, New South Wales hospitals actually, with a principal diagnosis of stroke. So they got to the hospital, they got a diagnosis of stroke. But we were interested in seeing what did the ambulance worker, what did they say was wrong with this person? So first of all, again, thinking about the big picture items, I know you can't read all these things, I'm not going to expect you to. In the middle of this figure is stroke. So the odds ratio, women compared to men, is about, I can't even read it myself here. Anyway, it's about 1, basically. It's just slightly lower than 1. So about a third of women and a third of men had the correct prior diagnosis of stroke. So they didn't do very well anyway, did they? Getting it right a third of the time is not particularly great. But again, women do worse in this case because, at least I'm sort of saying they do worse. There are some diseases at the bottom of this forest plot where men actually did worse. But the only times when there was big odds ratios were right at the top, because I put this in order. A lot of women got diagnosis by the ambulance worker of migraine, anxiety, and emotional distress. Now, while all those things are nasty, they're nothing like as bad as having stroke. So they actually had a stroke, but they got diagnosed as having anxiety. So I think it's fair to say that women were disadvantaged when it comes to the ambulance workers' diagnoses. So we've looked at an economic analysis after this, which, if you scale it up to the country as a whole, I mean, it shows. First of all, getting rid of the third. 2/3 not being misdiagnosed is a big issue, but bringing women up to the men's level overall saves an awful lot of money. It's millions when it's scaled up each year. We're also, again, trying to understand how we could change things. We're talking to the ambulance workers to try and see how we can help them to change the way that they diagnose stroke on a call out. Now, another example after a myocardial infarct. So this time I'm using American data. My institute is a global institute, so we actually look at American data as well. And again, Sonna Peters was the main author of this paper. So there's a lot to take in at this graph, so I'll try and take you through it. This is looking at the percentage of women and men, blue for men. No, it isn't, sorry, not on this slide. Sorry, get it wrong. In the solid lines are for men, and the dashed lines are for women. So if we look at the bottom, the blue ones, and looking over time on the x-axis at the bottom, over time, the number of people getting high-intensity statins, which is what the guidelines say should be done, the people who are statin initiators after their MI, the men have got higher percentages than women because the solid line's above the dashed line. If we look at people who took statins before, the red ones are looking at low and moderate intensity statins. Again, men have higher risks, so higher percentages rather than do women. And the top one is looking at prior high intensity statin users, where it's closer together, but there's still a male-female differential. And over time, you can see that the percentage has gone up, particularly for the blue and the red ones. That's because there was a change in the guidelines around 2011. If we look at the last year, which we had data here, in fact, it shows that women were 9%, because the odds ratio was 0.91, they were 9% less likely to get high-intensity statins amongst those prescribed statins within 30 days. So, why would this be? The national guidelines, with some caveats, admittedly, but nothing to do with sex differences. Every man and woman is supposed to get high-intensity statins after an MI, but 9% difference between women and men. Now, coming on to the underrepresentation of women in randomized controlled trials. So I picked the example of stroke here. So we looked at all the, this is using the, what's it called, the online registry of randomized controlled trials. We picked out all the trials over different years, and there's a dot for the percentage of female participants in any one particular trial. So we look back to the earliest data here is from 1990 to 2003, where there were a few trials. As we go through time, it gets a lot more on this registry anyway. I put the line of 50% there, so you can see, I hope, that there are relatively few dots above the line of 50%. So rarely are women overrepresented in clinical trials. And then the black line is showing the trend over time of the actual percentages on average. And it hasn't really changed very much over time, which actually was quite a surprise to us. We've done similar analyses like this of kidney disease and dementia, and other people looked at heart disease with pretty much the same messages. We've also looked at the percentage proportional to the population, which people often look at, which is another way of thinking about how the trial should represent women and men. So if there's more women who've got the problem, you should have more women in the trial. And of course, that depends upon age groups and lots of other things. But you find pretty much the same answer. There's still a female disadvantage. Now, what does it matter? I mean, you may say, well, it doesn't matter. I mean, some people say to me, oh, well, you can just scale it up. Scale it up. You give women a higher percentage weighting in the results than men. But that doesn't actually tell you anything about the sex differences. That just gets you a more reasonable, more representative overall picture. It doesn't say anything about the differences between men and women. You can only do that if you've got enough men and women in the sample. Anyway, so it doesn't, well, of course it could matter because you don't know whether an intervention might be harmful in women. Maybe it's more beneficial. We don't know unless we've actually got enough women and enough men to actually look into it. And the bottom bullet here, these data are old, but the very fact that they're old, I apologize for it, but to be honest, there's no update on this at all. 10 drugs which were withdrawn in that period, going back some time now, before a lot of you were born probably, 10 drugs were withdrawn from the US market because of serious side effects. And in 8 cases of the 10, it was greater risk for women than for men. So I think it does matter, and I hope you agree. But is it really feasible? is it really feasible to achieve sex equity? I probably haven't got much time to talk about all this, but perhaps I'll skip over it a bit. But the bottom line, I think, is the most important thing to point out. You may need to multiply a sample size by a huge number to get adequate power to test for a sex difference. That's what people think. It could be as much as 16, which of course nobody's ever going to fund a trial like that. And also, honestly, in practice, if you're trying to get recruits into a trial, when it comes to the end of the time period, you want to actually take whatever person you can get because you're running behind the schedule. So it is difficult to say you should have sex equity. But nevertheless, I think we need to look into the reason why women don't get into trials. Anyway, I think you should try for an equal representation. And if you haven't got a significant difference between women and men, that's fine. I mean, it's good. It's good. I mean, that's great. If you find the drug works as well in women and men, it's fine. That means you should give it to women and men, of course, in the same way. But if you don't find a significant difference, please just publish the results so we can do meta-analyses where we can get the sufficient power to find whether there is really a sex difference. But even when there are enough women and men in a study, one really annoying thing is that people often don't report it. It's not just annoying, it's actually risky not to do it. Although some journals recommend you should, or maybe they don't mandate it, but they usually recommend it at least. Our experience is it's not always applied. Many journals that say they have these ICMJE guidelines, International Committee of Medical Journal Editors, they don't actually do it, they don't enforce it. And in the UK, there's no funding body or regulator that adequately stipulate requirements around sex. We're well behind other countries, particularly Canada and the US. What might we miss? Well, here's an example of what we might miss. I've gone slightly outside the cardiovascular area, but dementia, this is a type of dementia. So vascular dementia is probably relevant to this too. This is a new wonder drug, which was reported on the New England Journal a couple of years ago. It doesn't really matter what the measuring is, but they found overall that for their primary endpoint, there was a difference overall between the intervention, that was the new drug, and placebo, with this minus 0.45, with this 95% confidence interval, which doesn't cover 0. So it's looking at a difference in the not a hazard ratio, but this time a difference on the absolute scale. Highly significant difference. So then they put this conclusion, it reduced markers of amyloid in early Alzheimer's disease, blah, 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 and on measures of cognitive and function, the placebo. So all's well and good. Now, in the paper in the New England Journal, they mention that they had a sex subgroup, but they don't even mention it in the paper itself. They don't actually make any mention of the results of the sex difference. And I apologize, this is a bit blurred because it was taken with a camera at a conference. I think the actual results are in the supplement to the paper. So anyway, but this is slightly blurred. But if I put if I add the line of minus 0.45, which is the overall difference, you can see that I hope you can see that the confidence interval, the length of the horizontal bar there, only just touches the end of it, the left end of it for women, whereas for men, everything's to the left. This looks like there might be a sex difference, I think, to the eye. They didn't do a test for significance, but actually the New England Journal doesn't let you do that anyway. But they could have put the difference of differences. Anyway, the point is they didn't actually say that, well, maybe, there's still a question about whether this really works in women. But, if you look at their conclusion, you say, hey, we'll give it to everybody. So we pointed this out, and JAMA Neurology published our opinion. Interestingly, they insisted we had an American as the first author. So we got an American as the first author. But anyway, at least we're able to point out the problem. So what should we know? Do we need sex-specific treatments? Should there be sex-specific doses of treatment? And would it be advisable to have sex-specific levels at treatment inception? And if we think about blood pressure control, which is probably the main thing, I think, where this has been a lot of conversation about this recently, Should women have different treatments, different doses, etc.? The blood pressure lowering treatment trialist collaboration has got 51 randomized controlled trials, and we've looked here at the sex-specific efficacy of these different drugs. So the top line is the ACE inhibitors, and if you look at the women and men results, the hazard ratios, this is for intervention with these drugs compared to placebo, with a network meta-analysis for things that did comparisons between drugs taken through the network to make it a comparison with placebo. Anyway, the point is they're almost exactly the same, the hazard ratios. So there's no difference. And it's the same for all of the different interventions, antihypertensives. And indeed, it was the same when we looked at baseline blood groups, age groups, and cardiovascular subtypes. So there's no difference, it seems, in the efficacy. But of course, that's not really the end of the story. And I've persuaded my colleagues that now we should look at not just the efficacy, but the safety. What about the ratio between the benefit and the harm? Maybe it's more harmful for women, like people seem to think for the high-intensity statins, as I mentioned in my previous slide. The last one was behavioural reasons. I think these are probably obvious. I'm probably not going to read them out. Bottom one, women are underrepresented in health research related to CVD. That's definitely true. Anyway, we'd known of this for years. It's not as if this is a new thing, what I'm talking about. This is Time magazine cover for 2003. I mean, it says about 1 in 3 women die of heart disease, etc. So it's not as if it's new, but women still don't seem to know enough about their risks. This Canadian study is, I don't know how good this is, but anyway, it's the only example I could find. I'm sure there are other ones out there that I missed. Largely without going into any details, they showed that women didn't know about their risk factors for heart disease, and they weren't aware of the symptoms which suggest that they've had a heart attack. So the numbers are quite impressive. Less than half knew that smoking was a risk factor for heart disease, for example. But again, I'll come back to what I said before. There's no control group here. I mean, how do we know that's not the same as that men have exactly the same sort of lack of knowledge? And if we know that we should do overall population interventions rather than concentrate on women. And then what about the professional level in terms of the representation of women at the top table, put it that way? We've done this, Kat Pino-Gomez is an ex-PhD student of mine from, sorry, I should say DPhil student of mine from Oxford, who's interested in this sort of stuff. We've done a lot of work looking at percentage of women as authors of papers, first authors, last authors, etc. And I mean, the bottom line with all of this is that women always do worse in terms of first or last authorship, except when it comes to retractions, where women are less likely to have their papers retracted than men. Interesting. Anyway, this particular work that we did, I think is interesting for this particular talk. We looked at the top 10 journals in each of these medical specialties, and we looked at the percentage of editors-in-chief that were women. There's only 3 areas at the top where it was more than 50%. The top one is genetics and hereditary, where women are more likely to be, the editors-in-chief are more likely to be women than men. Well, when it comes to cardiovascular disease, which I've showed you is a big problem for women, it's way down the bottom. It's well less than 20%. So, of course, that brings into question about the amount of research that's done in women compared to men. If you don't have women in the high positions, it probably doesn't trickle down in the way it should do. Hopefully this will change in the future, but it's still a problem. This is really recent data. So the limitations of what I've been talking about. Well, there's a difference between sex and gender, as I've said, and also they're not binary. They're not binary things. We know that. We really should look at all types of gender or sex. The LGBT stuff. I mean, it's really important, of course, but they don't come in big numbers. And I've been talking about using big data or systematic review to collect my numbers, my findings. But even in those, you don't find very many people who at least admit that they've got non-binary sex, or indeed are allowed to by the questions on the questionnaire, of course, in the first place. Other types of diversity, as this was just saying, basically, intersectionality is another thing which people often bring up. Of course, not all women are the same. I'm sure that women in low social status groups do worse than women in higher social status groups, and women in lower social status groups probably do worse of the 4 cross sections you can look between sex and SES. Of course, it's important, but again, when you break down the data, even with big data, you're not necessarily going to get huge numbers. We try to do that when we can, but it's not always really very useful. And then finally, the last one's very important. Absolute effects may be more important. I've looked at proportional effects rather than absolute effects. So risk difference may be what you should be looking at. So in clinical trials, people look at the relative risk. When people are publishing data, they almost always give you odds ratios, hazard ratios. So they're on the proportionate scale. We try to, when we're doing our own research from first principles rather than taking systematic reviews, we do the two. We look at both these things because they can give you very different results. Mathematically, you can show that you must get very different results actually with the sex differences. Now, I'm going to skip through because I want to give some time for questions. We've got 5 minutes left. Is that right? Anyway, the rest of it's, I think I've probably covered most of this. Lack of educational materials. That's a big problem, I think, that people don't have the education of how to do sex and gender work, segregation work. So my final slide, I'll go on to that. So I just want to say a little bit about what we're doing at the George Institute, if you'll bear with me for a minute. We're looking, we've got quite a big program in sex and gender research. It tends to not be in a particular center. It's spread across the whole institute, which is like about 800 people. We have centers in the UK, Australia, China, and India. We've established a national centre for sex and gender equity in health and medicine in Australia just recently. And in the UK, our work is part of a project called Message. I forgot what that exactly stands for, but we've published a policy framework. We've done co-design of policies both in Australia and the UK now. But this one, if you're interested in this, you could look out the George Institute policy framework for UK research in sex and gender. We hope we're actually writing this up for publication as well in the near future. And we've got websites and educational materials being developed. A new course at Imperial College is going to be in sex and gender. And finally, I'll just advertise my own little bit of work. This paper is, I thought I'd put together my ideas on how you can do sex differentiation work in general, actually, but cardiovascular associations specifically, to give some real life examples. And that's in Heart, which I think it's useful. My last slide, thank you for your attention. Thanks very much to Jill again, and of course to the legacy of William Walker. So thank you for listening.
Thanks very much. I'm subbed in for Jill, because this is being co-broadcast as Grand Rounds. I'm Tom Farden and I chair and organise Grand Rounds, and this will hopefully be some of the Grand Round audience who have tuned in to this excellent presentation, and we'll put it onto our YouTube channel once we've extracted the data. So does anyone have any questions that they'd like to pose? And I have to see if I can make sure that the technology works. Bear with me. It says trying to get the microphone to work.
If anybody here wants to ask questions afterwards, I think there's time.
We're all good. Introduce yourself and fire on.
I'm Jim Lang, I'm a cardiologist. Thank you very much for your tour de force on this subject. I wanted to question about the obesity-related complications and the excess risk that you talk about related to this. Because I'm a cardiologist. I'm interested in two particular conditions where there is a huge preponderance of women. Heart failure, in particular heart failure with preserved ejection fraction, and microvascular dysfunction in the presence of non-obstructive pulmonary disease, IOCA. Both these conditions are more common in women, huge comorbidities, and targeting these obesity, at least with semaglutide and for GLP-1 there is women who lose weight much more. And in the trials, with another drug class, there are drug differences and gender differences, sex differences in drug responses. Do you want to comment on this? There's clearly difference in specific diseases. Are there drug responses? How do you explore that?
So, I'm not sure I quite understood, but you're saying there's, sorry, you're saying that there's a difference in the prevalence, but there's no difference in the actions of the drugs. Is that?
We'll come back to drugs. So there is a sort of prevalence of obesity-related complications and excess risk.
Yeah.
In heart failure, preserved ejection fraction, clearly implicated, excess risk, microvascular. So how do you explain, you put out that cartoon of the residual cardiometabolic reserve risk, but is that the only explanation? And how should we understand this further? And can we, I'll come back to the question of drug treatment later. We can talk forever, but I just want to highlight that women, for some conditions, greater preponderance may be related to obesity, and how do we target that?
Well, I'm sorry, but I think it's a bit complicated, so I'm not quite sure I understand it. I mean, you say it may be related to obesity, so, I mean, okay. But I've not done any work in heart failure, I'm afraid. So, well, I have, but not in sex differences in heart failure. But it's certainly something that I know that we need to look at, and I have actually got one of the people whose work I presented, she's looking at heart failure differences in, sex differences in heart failure. So I may be able to come back to you on it, but please, I mean, if you communicate with me with what you've got, and I'm happy to help.
If I can follow on the drug trials.
Hang on, let the whole audience hear you.
The drug trials, of course, most of it were left to resorting to post hoc analysis and so forth.
Yeah.
And there are some trials that highlighted striking sex differences in drug response. Again,
yes.
They have PEF1 with sacubitril/valsartan, huge, that led to the FDA to specifically recommend this drug class for women because it's not effective in men.
Yes.
So I think more work needs to be done.
It does. I mean, I am aware of some of that. That woman I just talked about. I mean, she's in Utrecht, and she's published a paper showing exactly what you say. And there was a paper in New England Journal that showed a big sex difference. It's probably what you're talking about. So yes, in heart failure, there does seem to be a difference in the way that some drugs act. Yes.
Please. Slightly related question, because I was an undiabetologist, and I was looking at the high BMI women diagnosed with diabetes, and I can understand that. But then your relative risk factors, you had non-central obesity, and it were all as being a high risk factor for women than men. But I'm always taught, with all the traditionally, that of course the central obesity is a big risk factor, which is in fact for cardiovascular disease. So we need to rethink how we look at what we consider metabolic disease, or just that entire concept. Fatty liver is pretty much determining everything in cardiovascular disease. It may not be as simple as that.
Yeah, this is obviously a recurring theme with obesity research. You think of as you say, the central and non-central. I mean, statistically, to be honest, it doesn't look like there's much difference between the two. Whenever we look at waist circumference, waist to hip, waist to height. Actually, there's a paper today where it got accepted by the Lancet from the global burden of disease work that I've been doing. That looks, which you may like to look at. Again, we don't really find as much difference between them, despite the fact that it seems that etiologically it should be as exactly what you said. That BMI seems to be pretty good, despite the fact it was sort of on the back of an envelope for the guy at 200 or 300 years back or something.
Any more questions from the floor? I don't think anyone's monitoring the Teams chat. They are and there aren't. Okay, right, fine. Well, you're off the hook. Okay. I think looks like.
Well, as I said, anybody wants to come and talk, I'm happy to. I'm always looking for people who are enthusiastic in this area.
Is there some grub? Is it out there? If you've toughed it out this far in person, then there is food. There's lunch available.
One final thing, it would be really good to get the data from heart that you talked about, and also the guidelines about sex differences, and the importance of sex differences in research, because I think that's something we as a school should think about much more in terms of our clinical trials, and so having those guidelines would be great. So we just figure out how to circulate that afterwards to make everybody aware.
Yeah, I should have added that I went to see Anna Glacier, who's the women's champion for Scotland last year in Edinburgh, and she's interested in this particularly the policy document you just said. So we have actually my colleague who works in Edinburgh. She's leading the research basically. So yes, I'll send it to you. But we are interested in looking at Scotland specifically as well.
That would be great, and I'll circulate that and make sure that we've seen.
Okay, so that brings us to conclusion. One last thing is to thank again Mark for his excellent talk and for your input with the questions. Grand Round returns next week or back on Zoom. Please do tune in, and this will go on YouTube whenever I get round to it.